physiological function. And so we continue that theme in this presentation. So you can see that we're not focusing on how to treat thyroid disease, but how to address thyroid dysfunction. I have many conflicts, I have many interests, I have no conflicts of interest. It is a good life. On the topic of function, let's go back to the old adage. Form follows function. What does function follow? In other words, if function determines form, what determines function? What determines physiological function? Because that's what you're going to leverage on Monday. You can change physiological function without labs, without supplements, based on the training you've had this week. That's the end goal of this presentation. So with that in mind, let's think about what is a supplement. Supplement is a substance that's naturally occurring in the body, contributes to optimal physiological function. And a principle of functional medicine would be this: no supplementation without optimization of physiological function. Address the matrix first. You know that the matrix informs us of function. There's something else that we'll get to in a moment. So, what is the status quo of treating thyroid disease? You have a patient with hypothyroidism, and you're actually giving them a supplement. T4 naturally occurs in the body. You end up with a patient with hypothyroidism who's now taking a supplement. That's good population evidence-based medicine. Functional medicine sees it differently. You have a patient who has a thyroid gland that starts out with a normal function, and that patient encounters an adverse environment, and the thyroid gland either appropriately responds and alters its function, or it becomes impaired by that environment. So the solution for functional medicine practitioners is not to give a supplement, but to take that patient with impaired function or altered function of the thyroid gland, assess and address their environment to achieve a thyroid gland with improved function and a patient who feels better. So this is the difference in thinking between 20th and 21st century medicine. 20th century medicine, good population evidence-based medicine. How do we treat hypothyroidism? We treat the effects by replacing the deficiency. 21st century, good personalized evidence-based medicine. Address the underlying causes, restore function. Because what also happens? What about the underlying causes of thyroid dysfunction? Do they also cause other diseases? And if they're not addressed, are we dooming that patient taking T4 to developing other diseases that are just in their latency phase now while we're giving them that supplement? Making them feel better, yes. But what are we doing to prevent the other diseases which have maybe some of the same causes? So here's the trajectory of thyroid disease as we currently treat it. We diagnose, we initiate T4 replacement, good evidence-based medicine. We increase the dosage, and probably comorbidities emerge. By the end of this presentation, let's shift our thinking and shift that trajectory. We may need to initiate T4 replacement to help the patient feel better. But then, let's initiate functional medicine interventions. We can get improved thyroid function. We might be able to lower that T4 dose. We might be able to get the patient off of T4 and prevent those comorbid conditions. And you can do it with what you've learned in this course thus far, and many times without labs, without supplements. And this is how you'll do it. Here's a diagram of the principles of functional medicine when you encounter a deficiency state. In the center, you'll see conventional care and the deficiency state and what we usually do. We either replace what's deficient or we reduce the catabolism of what's deficient, as we do with SSRIs, for example. What are the principles now of what to do with functional medicine when you encounter a deficiency state? Start from the top. Nutritional interventions that either increase the production or the availability of that agent. Food first. Next. Lifestyle and behavioral and epigenetic interventions. What epigenetic interventions have you learned in the course thus far? Stress reduction, nutrition. Those change gene expression. Next principle, Deficiency state, the removal or the reduction of any antecedents, triggers, or mediators that reduce the production or decrease the availability of that agent. You have started to learn how to do that in this course. You can do that on Monday now. Next, then, if these first three types of interventions do not succeed, consider nutraceutical, supplemental, or other integrative modalities, and always make sure that the magnitude and the likelihood of benefit and harm is balanced and in your favor and in your patient's favor. If form follows function, function follows environment. It's the environment that determines the physiological function. And you can address the patient's environment on Monday. Again, without labs, without supplements. This is an outline of where we're going in this presentation. It's dense, but we're going to take it a chunk at a time. Let's focus on those two words, function and environment. This is the environment in which the thyroid is bathed. Nutrient-depleted soil, nutrient-depleted foods, stress, toxins in the environment. Jeff Bland has famously said the thyroid is the sentinel for the environment. Think about it. This gland is designed to change its function in response to the environment. As the environment changes, the function of this gland will change. That you need to think about when you're addressing it therapeutically. Our performance objectives. First, we'll start with signs, symptoms, and conditions that are correlated. Next, what you've learned in this course so far. How do those ATMs explain the high prevalence of thyroid dysfunction? Next, PTSD. You've just been introduced to that. The antecedents, triggers, and mediators that you've learned about influence production, transport, conversion, and sensitivity of thyroid hormone. Next, questioning TSH as the only test to use. We'll get into why that is in just a few minutes. Finally, how you can use what you've learned in the course thus far, especially antecedents, triggers, mediators, modifiable lifestyle factors, to improve thyroid hormone production, transport, conversion, and sensitivity. You can do it on Monday. This all has to do with function, every single performance objective. And now you have a sense of how function is represented on the matrix. How is the environment represented on the matrix? Antecedents, those are past environmental predisposers, are they not? Triggers, those are environmental activators, whether it was a triggering event or a triggering pollen or a triggering food. Mediators, current environmental perpetuators of dysfunction. Modifiable lifestyle factors, current behavioral environmental promoters of dysfunction. Mental, emotional, spiritual factors, the internal mind-body environment. And the 7 nodes of the matrix represent the internal physiological environment. The 3 nodes of the matrix that we will ask you to focus on for addressing thyroid hormone dysfunction are the assimilation node, the defense and repair node, and the biotransformation elimination node. What we're going to ask you to do at this point in your training, and starting on Monday morning, is to focus on 8 environmental domains. You'll get much more advanced training in your hormone advanced practice module of how to address thyroid conditions. But for now, focus on these 8 domains. You'll recognize the 5 on the bottom as the modifiable lifestyle factors and the 3 nodes of the matrix that I just called out. Think about food antigens and gut function, infections and inflammation in defense and repair, and toxins down in biotransformation and elimination. Next chunk of content, the effects of thyroid dysfunction, the question of screening, and then how do those ATMs explain the high prevalence? So this gets at our first performance objective. The clinical effects of hypothyroidism are challenging to diagnose because they are so common in the general population, and they are so widespread and ubiquitous throughout the body. The standard textbook even says it can affect any organ system. Our matrix, when we fill it out with the usual suspects, we'll get ink on all aspects of the matrix, all the nodes of the matrix. The prevalence, 1 out of every 7 adults has a low-functioning thyroid. But the problem is, of all the individuals who have 4 or more symptoms of low thyroid function, only 1 of 8 has low thyroid function. So a lot of people are walking around with a lot of thyroid symptoms with normal functioning thyroid glands. It's time to introduce our case for the next day, and today and tomorrow, and the next few chapters of this course. It's Helen, a 54-year-old female. This is a bust of Helen when she was a much younger woman. In fact, she was quite a famous teenager when she was famously kidnapped from her hometown of Athens and brought to Troy. And when you ask her, when did you last feel well? I never felt well after the day that horse rolled into my town, and at night these marauders spilled out of its gut, burned, sacked, raged, pillaged, and set fire to our town. I've had gut problems ever since. That's a precipitating life event, if we've ever heard one. And let's look at Helen's timeline with depression and headaches. Now, she cannot sleep. She cannot think well. She's got brain fog and memory loss, and she cannot lose weight, especially around the middle. Does Helen have hypothyroidism? Does she need to be screened? Is she expressing low thyroid function? What about screening? How do we make recommendations for screening if the symptoms are so common in people with normal thyroid function? And as a result of that, let's go to the guidelines and the specialty recommendations. They're all over the map. The ATA is very aggressive. Start at age 35 every 5 years. The Royal College of Physicians says it's unjustified to screen. And the USPSTF recommends against it, insufficient evidence. And the concept of screening when symptoms are so common in the general population needs to be reconsidered. And that's why the guidelines have really come up with something called aggressive case finding. Which patients should be tested to assess for low thyroid function? And this comes from the most recent guidelines from the American Association of Clinical Endocrinologists and the American Thyroid Association, their 2012 guidelines. Recommendation 21, aggressive case finding should be considered in those at increased risk, which begs the question of who is at increased risk? Anyone with an autoimmune disease. Test for thyroid function. Family member with autoimmune thyroid disease. But look at the next ones. Anybody with a psychiatric disorder, anxiety, depression, how often do we see that? Justification for aggressive screening, right? Or aggressive case finding, I should say. If you've had thyroid surgery, or even a history of thyroid dysfunction in the past. So we like to say, we put this together, the Canadian Task Force, we think has put together a pretty good recommendation, which is vague, but it's really on the mark because it says maintain a high index of clinical suspicion, be a good doctor. Take a good history and put the whole context together. And of course, we are going to help you do that with a toolkit questionnaire, the thyroid screening questionnaire, which is not validated, and yet our clinical experience informs us if 3 or more questions on this are positive, that nudges you towards really considering aggressive case finding of thyroid dysfunction. Let's get to know Helen better now. She's a 54-year-old female. She's had fatigue for 20 years. This is her family history. Aggressive case finding? I see hypothyroidism. Is it autoimmune? If it is, aggressive case finding warranted. We know that she's got digestive complaints for about 40 years now. High dose of levothyroxine. That's a high dose of that supplement. Let's think about 4 reasons why she might be on such a high dose. 1, severity of her condition. Maybe it's severe dysfunction and she needs a high dose. 2, is she taking that thyroid medication? Does her doctor keep testing her and she's not really taking it and she keeps getting a high TSH? 3, how is she taking it? Is she taking it too close to food or other medications? 4, come on, functional medicine physicians now. PTSD. The T also stands for the C here, conversion. Is the T4 supplement we're giving her being converted to T3? All right. What does this last item tell you about the timing of the onset of her hypothyroidism? 3 pregnancies carried to full term within 4 years in her late 20s. Did she have hypothyroidism then? Unlikely. If you can do that, you're unlikely to have hypothyroidism. Okay, so let's now look at our second performance objective. How do the ATMs that you've learned in the course thus far explain the high prevalence of hypothyroidism. And let's think about them in the context of those 8 domains I mentioned. Some statistics, we could have pulled many statistics, but here's a few of them. 2 out of 7 women have evidence of autoimmune hypothyroidism in this, or autoimmune thyroiditis in this study. And return to what Dr. Bland said, it's the sentinel gland for the environment. It's designed to be induced or suppressed by changes in the environment, which is your leverage for therapeutic intervention. As the environment changes, the function of the gland will change. The thyroid gland is the canary in the coal mine of our toxic world. Think about what you learned earlier in the course, the cause of the cause of the cause. The antecedents, triggers, and mediators represent the cause of the cause of the cause here. And instead of just typically treating it with T4 replacement to address the effects and the consequences of the autoimmunity, by giving replacement, let's address the whole go to it, to address those antecedents, to address those triggers and those mediators. And the triggers are often going to be in those 3 domains. Antigens, food antigens especially, but also toxins and microbes can trigger this. And then the mediators are often modifiable lifestyle factors and barrier disruption, especially that permeable intestine or leaky gut. Let's get to know Helen a little better here now. For her headaches, she takes OTC meds, ibuprofen. What does that do to her permeability in her intestine? How does that contribute to autoimmunity and perhaps her thyroid function? Can we address that? She frequently has trouble getting to sleep. Might that be due to stress and a stress hormone that you just learned about? What is that stress hormone? Does cortisol affect thyroid function in any way? Which aspect, PT, S, or D? Depressed mood. What did we say about that in aggressive case finding? All right, there's a psychiatric condition. Here's her stress profile, which does not include the divorce she went through, followed by becoming a single mother of 3 children. Here's her nutrition profile. Inflammatory or not inflammatory? Inflammatory. What does inflammation do to thyroid function? And does it affect PTS or D? Now she tells you, you've started to get to know her well enough. Doc, I stopped taking that levothyroxine 3 months ago, and I haven't really noticed any difference. What do you want to do next? Who would test her now? Find out where we are. Here's where we are. TSH, 10.76, quite elevated. Free T4 normal, in the lower end of the range of normal. What's her diagnosis? High TSH, normal free T4. Subclinical hypothyroidism. Okay. She declines to restart the medicine and says, how can you help me feel better without pills? Can you do this on Monday? Yes, you can. Okay, because you're going to address PTSD with what you've learned in the course thus far, your ATMs and your modifiable lifestyle factors. So let's look at which of these ATMs and MLFs affect production. And we'll focus on these 5 areas. Here's a slide that depicts the steps of production, transport, conversion, sensitivity, and detoxification of thyroid hormone for your reference. For production, we focus on the upper right. Hypothalamus produces TRH, pituitary produces TSH, stimulates the thyroid to produce the T4, and we go on then to transport, conversion, and so forth. The question to ask now, is the patient's thyroid hormone production low because it's been impaired by the environment, or is it low because it is appropriately altering in response to the environment? Nutrients that you need, food first. Nutrients that you need to make thyroid hormone. Here they are. If these are missing, is the gland impaired or is it altered? Is it altering? This would impair thyroid function. You don't have the nutrients you need. Okay? Now, take a look at this next slide. In this, there are conditions, environmental conditions, which some of them impair and some of them cause the thyroid to appropriately alter its function. Which is which? Stress, infections, trauma. Under those conditions, the thyroid appropriately alters the activity of thyroid hormone. In the rest of them, radiation, fluoride, toxins, pesticides, goitrogens, autoimmune conditions, The ability of the thyroid gland to produce T4 is impaired. Okay, so how can you use nutrition on Monday to help address this? First, assume that anybody who comes in with low thyroid function has some nutrient deficiencies. What is circled there are those nutrients that the thyroid needs. This is the population-based data of the prevalence of nutrient deficiencies. You can almost assume your patients are going to be nutrient depleted. Iodine deserves special call out because it will cause low thyroid function if it's either in excess or deficiency, and there are certainly advocates of mega doses of iodine out there, and we do not concur with that. We like to follow the, follow the guidelines that recommend up to 500 micrograms, only exceeding that if there is clinical indication or laboratory evidence of a need for that. Helen's nutrition profile. What can you do to help her? How are you going to get this with food first? These nutrients. Do you think she's depleted in these nutrients with that diet? I'll bet she is. So let's do it with food first. What nutrient is she going to get from this food? Selenium. This food group will give Helen what? Those are your zinc foods, okay? How about this food group? Go with your meat and spinach there. Iron. Her thyroid needs iron. How about this food group? Notice the foods from the ocean. Iodine is that group. This food group gives you which essential nutrient for the thyroid? Look at the color. Vitamin A. And this food group gives you which nutrient, especially if you eat it outdoors with short sleeves and shorts on? Vitamin D. Okay. And of course, we're going to help you with this with your toolkit. You've got a handout for each of these food sources to give to your patient. These 6 pages can get you started on Monday morning. 6 handouts, your patient takes these home, better thyroid function, no labs, no supplements. If you need to supplement, this is your reference slide. How can you affect a patient's stress and help them achieve lower stress levels to affect thyroid hormone production? Well, you've seen this now. That's the pathway from TRH to T3. Stress produces cortisol. What does cortisol do to your TSH? Knocks it down and knocks down the conversion of T4 to T3, preferentially causing you to produce reverse T3. So stress is truly a reducer of thyroid hormone production. Helen's stress profile. What can we do about this? We have an evaluative tool, the HPA Axis Questionnaire, a great tool to give to your patient to help you address and assess the stress and the sources of stress in their life. And interventional tools, breathing techniques, mindful breathing, strategies to transform stress. Monday morning, you can use these. If you can engage your patient, motivate them to use these, improved thyroid function, no labs, no supplements, no cost. Close your laptops here just so you're not looking at the answers. Let's do a little telling and prioritize. Stand up and just let yourself stretch for about a minute here, but we're going to take partners here, pick a partner, and one time you're the doctor, one time you're the patient. And for 30 seconds, the doctor will explain to the patient how their stressful life events might decrease their thyroid hormone production, then switch partners, and the patient becomes the doctor, and you explain to your partner how a daily stress reduction practice could increase the production of thyroid hormone and help you feel better. Okay? Just a 30-second exercise for each of you, just to get used to telling that story. As you've heard now, the most important skill in functional medicine. Go ahead, 30 seconds each.